Comparison of non-ST elevation versus ST elevation myocardial infarctions in a large tertiary care center of critical care patients. Student members for this project were Neha Panigrahy, Rahul Ramanathan, Anton Christensen, and our faculty advisors, Dr. Gao and Dr. Lee. Coronary artery disease, or CAD, and its implications. Coronary artery disease is the occlusion of coronary arteries, which are the arteries that supply blood to the heart. One of the most severe sequelae of CAD is acute myocardial infarctions, or AMIs. AMIs are when occlusion causes cardiac muscle death and are responsible for 800 to 500,000 deaths in America annually. CAD affects 7.2% of Americans and more commonly affects the elderly. It's estimated that CAD cost the US $229 billion in 2017 alone. STEMI versus NSTEMI. STEMI, or ST elevation myocardial infarction, is typically caused by a ruptured coronary artery plaque, which results in a clot and then an occlusion, normally a full occlusion of a coronary artery. STEMIs are characterized by a higher degree of occlusion of coronary arteries compared to NSTEMIs. NSTEMI, or non-ST elevation myocardial infarctions, can be caused by a variety of flow-limiting conditions. Some of the common causes are stable plaques, vasospasms, emboli, and arteritis. Previous investigations have found that STEMI is significantly associated with smoking and alcohol abuse. NSTEMI, on the other hand, is more associated with unstable angina, hypertension, dyslipidemia, and acute coronary syndrome than STEMIs are. Male sex is also associated with higher rates of CAD and a 7 to 10 earlier age of onset in comparison to females. The objectives of this project were to analyze the epidemiological and systematic factors of patients with NSTEMI versus STEMI, and additionally, the demographics, hospital course, and in-hospital data of patients with STEMI versus NSTEMI.
So the methods to analyze this data were done by obtaining a large data set called MIMIC-3. So this is a data set that's composed of 50,000 critical care patients across a decade at a large tertiary care center in Boston. This data set contains 26 tables of data with a lot of admission information. A brief summary of the data set includes patients with a median age of 65. Their ICU state was 2 days, and all-cause hospital mortality was 11%. What's really unique about this data set is each patient had 4,500 observations and 308 lab values recorded. And the top 3 diagnoses in this data set were coronary atherosclerosis, septicemia, and subendocardial infarction. So data acquisition for this data set was done by using Spider IDE under Python, and we extracted data with STEMI and NSTEMI recorded. And we also recorded various parameters. Furthermore, we use MATLAB for statistics and box plot generation. So some of the results and discussion are going to be following. So to start off, we looked at gender distribution in NSTEMI subgroup and the STEMI subgroup. We found that males were significantly more at risk for CAD and AMI in the US. And this is something that we also found in our study, where a majority of the patients, about 65, were males. However, we did not observe any statistical significance between the NSTEMI and STEMI subgroups. Next, we looked at ethnicity of the admitted patients. So when we looked at ethnicity, we observed that the white ethnicity had the largest proportions of AMI. However, this was done in Boston, and majority of the city's population is of white ethnicity, about 50%. A limitation during this portion was that 13 to 17% of patients in this study had an unspecified ethnicity, which serves as a limitation because we were unable to obtain their data. Next, we also looked at religion of patients. We observed that majority of the patients were Catholic. So in the NSTEMI subgroup, that was about 48%, and the STEMI was 50%. Catholicism reported more significantly than any other religions, with a p-value of less than 5%. However, we didn't notice any difference between the 2 subgroups. Next, we looked at marital status between NSTEMI and STEMI patients. We observed that significantly more married patients were suffering for MI when compared to divorced and separated. However, again, we did not find a significant difference between NSTEMI and STEMI subgroups. Another demographic data that we looked at was the insurance status. And we observed that the significant majority were actually Medicare patients. So in NSTEMI, that was 70%, and the STEMI subgroup, it was 65%. It's not surprising because the average age of the first MI in males is 65 and in females is 72 years in the US. So it's expected that, majority of the patients in our study would, fall under Medicare insurance.
We also looked at the description of the hospital stays for our NSTEMI and STEMI patients. We found that the majority were actually transferred from another hospital, 62% in NSTEMI and 60% in STEMI, but no significant difference was found between any of the groups. For the discharge location, we found that majority of NSTEMI patients were discharged on home health care, while the STEMI patients were typically discharged to home without further care. This may be due to the fact that NSTEMI patients typically have a lot of comorbidities that require a longer hospital stay and thus may translate to more close care at home. We also looked at the time spent in the hospital during a single encounter and time spent in the ICU during a single encounter. NSTEMI patients actually significantly spent longer in the hospital, 9 days versus the 6 days for STEMI patients. And actually, in the ICU, they didn't spend a significantly different amount of time. We also looked at interventions for both NSTEMI and STEMI patients in the form of percutaneous coronary interventions, or PCI. We found that overall, STEMI patients actually went through percutaneous catheterization and stent placement more often than NSTEMI patients. And we found that the relative risk for receiving catheterization as an NSTEMI patient is 61% compared to being a STEMI patient. And absolute risk reduction was 98.1% for that group. And this may be due to the fact that NSTEMI is typically treated with medical stabilization, whereas the treatment for STEMI typically includes percutaneous coronary intervention. And the stent placement, as I mentioned before, the NSTEMI group received less stent placement, which is concordant with the fact that they are less commonly catheterized overall.
Another thing we looked at was the co-diagnoses in the patients. So unsurprisingly, the STEMI and NSTEMI patients both had the highest proportion as CAD. So CAD, or coronary artery disease, was the most common co-diagnosis. However, in NSTEMI patients, the patients had a higher rate of heart failure. One possible reason for this is the higher rates of higher rates of percutaneous coronary intervention in STEMI patients could possibly prevent future comorbidities like heart failure. However, in the STEMI subgroup, the patients had a higher rate of hypertension and hyperlipidemia. These two risk factors are well studied in myocardial infarctions and have been cited to be the most common comorbidities in these patients. So to conclude, NSTEMI patients typically had a longer hospital course, possibly because they had chronic comorbidities that contributed them to stay longer in the hospital. Oftentimes they had less intervention in terms of PCI and stents. And they were also discharged to home health care, which means they were requiring more support when they left the hospital. In comparison to their STEMI counterparts, these patients typically had a shorter hospital course, possibly due to the acute nature of STEMI, and they also had more immediate interventions via PCI and stent placement. And oftentimes these patients were discharged to home without further care, possibly due to the fact that they were less sick to begin with, but also they got immediate interventions. And that's all we had. Thank you.
Thank you.